Good evening, everyone, and thank you for joining us for the OTEP clinical case webinar. My name is Jale Gholami, and it's my pleasure to be hosting tonight's session. Tonight's topic is the impact of opioids on the endocrine system, an often overlooked area that can make a real difference in how we manage OUD patients. And I'm honored to introduce our speaker, Dr. Chris Tremonti, addiction medicine specialist at St. Vincent's Hospital, who is well placed to guide us through this topic. Before we get started, I'd like to acknowledge the traditional custodians of the land on which we meet today and pay my respects to their elders past, present, and emerging. I also extend my respect to any Aboriginal and Torres Strait Islander people joining us today. Here is a quick overview of where everyone is joining from this evening. This is based on the registration list, not actual attendance. It's encouraging to see participation from a range of LHDs, including strong representation from metropolitan areas and a solid mix of attendees from regional and rural LHDs across New South Wales. We have 44% from metropolitan areas, 38% from regional areas, and 80% from other states and interstate areas. We are pleased to see a wide range of specialties and roles represented among tonight's registrants, reflecting a diverse level of interest in this webinar. Welcome again to everyone who has joined tonight. This is the 7th webinar of 2025. As you may know, OTEP clinical case webinars are held monthly on Tuesday nights. All webinars are recorded, and the recordings are available on the OTAC website. And each certificate will be emailed to attendees, which can be used to self-claim your CPD points. To ensure a smooth session, please keep yourself on mute unless speaking or asking a question. If you have a question, please raise your hand in Zoom. When invited to speak, unmute yourself and turn on your video. We will also have a few Zoom polls during the webinar, and we encourage you to participate. Just a quick reminder that this webinar is being recorded, so please avoid sharing any confidential or identifying information during the session. Now, over to you, Chris, and please tell us a bit more about yourself before you begin.
Thanks, Jello. Well, yes, thank you for that wonderful introduction. My name's Chris Tremonti. I'm a staff specialist at St Vincent's Hospital in Sydney. I also do a little bit of private work as well. What I'll be sharing today, which hopefully is sharing now, it's not, hopefully, hang on, just let me share. This is my emails for some reason. I don't know where my presentation's gone. There it is. What I'll be sharing, mostly drawing on today, is some research that I've been doing as part of my PhD, which has also involved the ATOS study, which is the Australian Treatment Outcome Study, which is the 18 to 20 year follow-up of 615 people with heroin dependence. We were lucky enough to have 130 of those participants come and do a formal physical health assessment with us. And so some of the data that you'll see today, whenever I say it's sort of our research, it's from the ATOS collaborative, and I'm grateful to Professor Paul Haber, to Professor Murray Thiessen, to Dr. Chris Morell, and Professor Catherine Mills in the ATOS collaborative, who are all very important members of that team that have been doing that important work for a long time. It's obviously been very challenging to get follow up 615 people, but they've managed to follow up around 3/4 of them, which is an extraordinary effort in a long-term study that's been going 20 years of people who've got heroin dependence. So it's going to be a bit of a whistle-stop tour through each of the endocrine systems tonight. We're going to be looking at the hypothalamic pituitary gonadal axis. We're going to be looking at the hypothalamic pituitary adrenal axis. We'll look at the thyroid, prolactin, and we'll also just briefly touch on diabetes and metabolic, which is a little bit different in that it's not really an axis-based hormonal system, but it's still something important that we need to talk about as well. do please jump in. If people have got questions, put your hand up, and I'm more than happy to answer questions as we go along. So I thought I'd start with a clinical question. We've got a 53-year-old female. She's been known to you for 10 years because she's on opioid use disorder. She's had a 12-month history of amenorrhea. She's got opioid use disorder, GORD, hypertension. She's on methadone 125 milligrams, pantoprazole 40, and ramipril 2.5 milligrams. You do some investigations, and her estradiol is 30, so that's very low. You've got an LH, which is 5, which is in the normal range, and an FSH, which is also in what you would consider a normal range for somebody in their for a woman in their luteal or follicular cycles. So, what is the most likely cause of the amenorrhea? We'll do a quick poll. And we'll give everybody about 10 more seconds or so. Being a presentation about opioids and endocrine systems, might be a slight giveaway as to what's going on. what I'm sort of angling towards here. In all honesty, I mean, it's certainly. Have we got the poll results there, Jello? So most of you, yeah. So look, I understandable that many of you said menopause. I did make her 53. It's probably a bit older than I probably should have made her 46 or something like that. But so potentially menopause is possible as well. But what I'm trying to get at with this question was in particular that the FSH and the LH levels were not elevated. So what you would expect to see in menopause and what you would expect to see in other sort of primary hypogonadal conditions is that the estrogen or estradiol would be low, but their LH and FSH should be high. So whenever we have a failing axis, that's what's meant to happen, unless the axis is failing at a different level. So if we move on to look at the actual axis, the hypogonadal pituitary, the hypothalamic pituitary gonadal axis, we have the hypothalamus, and that makes a GnRH, which then causes the release of luteinizing hormone and follicular stimulating hormones that go to either the testes or the ovaries in order to cause the release of testosterone and estrogen, respectively. Now, as I say, in the case of opioids, there is there is an interruption of this axis due to opioids. So this, I guess, leads us to the next question, which is where is the main interruption of the HBG axis due to opioids? Why did that click forward? Everybody got a bit of a clue there if you're paying close attention. And so we'll give everybody a few moments. You probably all caught that. Do you have the results there, Charlie? Yeah. So either you knew it or you quickly caught that you saw it was bolded on there on my slides there. But yes, so the axis, so opioids suppress the release of the gonadotrophin releasing hormone, that's GnRH, which then causes an on-flow effect that it's low, that therefore there's less release of LH and FSH, and as a consequence, then obviously less testosterone in men and less estrogen in women. For reasons I don't fully understand, the LH does get the luteinizing hormone release is affected more than FSH. It's not really clear why that is, but certainly as I say, it inhibits the pulsatile release of gonadotrophin releasing hormone from the hypothalamus. That's that there. Which then, as I say, has a knock-on effect there, in particular for luteinizing hormone. Oh gosh, the question's coming thick and fast here. So, what percentage of male patients prescribed opioids, I'm going to make sure it doesn't click forward and give away the answer, are affected by hypogonadism? So you can guess 20, 40, 60, 80. We got some results coming in there, Jello. Okay, yep, okay. So not many people thought it was everybody. I think most people went middle of the road. Very smart advice when you're doing any sort of multi-choice question. But look, there was a big. This is based on a very large meta-analysis that was conducted, and this is across opioids, a variety of different opioids. So this is not just limited to the opioids that we use in opioid agonist therapy, like buprenorphine and methadone. This is also including studies that used hydromorphone, morphine, fentanyl, et cetera, et cetera, et cetera. But across these studies, there was a rate of about 60%. So it is quite a significant problem. It's probably something that we don't look at and investigate and manage perhaps as well as we should. And there's probably still a lot of unanswered questions that remain about it, such as, well, which is the worst opioid for it? What's the better ones, et cetera, et cetera. So yes, I mean, it really does vary in all of these different studies. There's literally dozens of them, and there's some suggestions that perhaps being on a long acting is worse for suppressing because it's a pulsatile release of gonadotrophin releasing hormone. Therefore, being on a long acting opioid like we have with methadone and buprenorphine could be worse. The route, so whether or not taking it intravenously potentially could be worse. Whether it's prescribed and recreational, obviously that creates challenges in terms of trying to gauge quantities. We don't know how much, we like to estimate how much heroin and so forth, people are using. But if people are using something recreationally, it can be hard to gauge the amount that they're taking. In terms of dose, look, there probably is a dose-dependent relationship, and it also depends on cutoffs. So various labs will use different cutoffs in terms of testosterone level to say that a man has got hypogonadism, or a different cutoff with estrogen. It tends to be more. It tends. Testosterone tends to be much vaguer, so there's various cutoffs depending on various different societies. Whereas in the study we did with regards to declaring that somebody had opioid-associated hypogonadism, we had specific criteria, which was basically that somebody had to have a woman had to have a suppressed estrogen with an LH and an FSH that wasn't elevated, and there wasn't evidence of other reasons why that might be so, such as menopause or contraceptive pills or whatever else. So with women, there can be quite a clear-cut definition. And I think in part this clear-cut definition actually also impacts the rates. Our research demonstrated there probably wasn't a big difference between the genders, whereas most other studies have suggested that men are more affected than others. But I think it's much easier to just have a one-off test of testosterone and go, oh yeah, that's low, as opposed to having, a woman that's had, missing their periods for 12 months and then have to undergo testing and meet these criteria and so forth. So, yeah, anyway. So in terms of methadone specifically, it's a rate of about 40%. And that was in a study done by Yi. In women, there's no actual published study. I'm working on that, that has a defined rate of secondary hypogonadism in women that are taking methadone. But there was a study about 20 years ago that suggested about 75% of women have an abnormal menstrual cycle. And it has been suggested that the rates of opioid-induced hypogonadism was about 20%. But this, as I say, was in a variety of different opioids. Again, much like a lot of research, unfortunately, that research has been much more male focused, and women have unfortunately neglected in this area, and it is certainly something we we need to work on and improve. Within our study, there was about a third of participants who were women, and that tends to be a pretty common theme across the addiction sphere. So it would be good to get those. Well, it's not good to have people getting addicted, but it'd be good to have more women who do have issues with dependencies being involved in these studies. And as I say, then look, our rate of opioid-induced hypogonadism in that study was about 20% as well. So the signs and symptoms that you might see for people who've got opioid-induced hypogonadism: reduced libido, fatigue, amenorrhea, as mentioned, low mood, irritability, poor concentration, hot flushes. I put a little star on erectile dysfunction. It doesn't so methadone in and of itself and many other opioids can cause erectile dysfunction, but erectile dysfunction is a very complex interplay of a lot of different hormones and mechanisms and so forth, and physiological mechanisms and so forth. And it's not necessarily the hypogonadism itself that causes erectile dysfunction, but it's often the two often do go hand in hand. All right, another poll question. So what are some other causes of central hypogonadism? So what I'm talking about with central hypogonadism is hypogonadism that is caused due to suppression of gonadotrophin releasing hormone or luteinizing hormone and vesicular stimulating hormone. So at the level of the brain and the hypothalamus and pituitary. Look, I mean, anybody who's done any multiple choice exams over their journey will know that you always go all of the above. So all of these things can cause central hypogonadism. So you do need to, when you've got a patient in front of you that's got suppressed sex hormones, then you want to try and optimize these things as much as you can as well. The sequelae is also, I mean, it is, there are some important health consequences. Obviously, people's sexuality is important and their sex health is very important. But also there's some other important sequelae that come out of having hypogonadism. So in particular, osteoporosis. So anybody that's got evidence of opioid-induced hypogonadism really does need to have a bone mineral density scan. They can have sarcopenia, so that's the loss of muscle. They can increase adipose tissue and have gynecomastia as well. And the adipose tissue increase is important because, as on the slides a moment ago, obesity in and of itself can cause hypogonadism, and so you're then left with a rather vicious cycle, unfortunately, of creating more and more adipose tissue, and at the same time that leading to more and more hypogonadism, etc., etc., etc. So the diagnosis. So I mean, look, first and foremost, you do need to exclude other causes of hypogonadism. So, you and especially when you're looking at younger patients and so forth, you then need to see evidence of a suppressed estrogen or testosterone, and as I say, with a normal or low vesicular stimulating hormone or luteinizing hormone, because as I say, they should be elevated if it was to be a primary cause of hypogonadism. So if it was a deficiency caused by the testes or the ovaries. It's also worth checking their iron, prolactin, whether or not to do an SHBG. I don't know if there's any endocrinologists listening in, but people, it was always the teaching that we should do. This is a sex hormone binding globulin, which is basically, if it's present in high levels, it can bind to more testosterone and therefore or estrogen, and then cause cause incorrect results. So it's a way of sort of testing for that to see whether or not there's free testosterone and so forth. It's funny though, you always get taught to do it, and then the cutoff levels for it are vague when you go and start looking for what is the correct testosterone level based on a sex hormone binding globulin. So I don't know if it's as good as people say. Testing should be done in the morning. So and really it should be done twice if you're going to test for it as well. There are, as I say, different cutoffs depending on age. So men do start to produce less testosterone as they get older. Also, obviously, for women, once they reach menopause, that's a factor as well. But for with menopause, you would expect to see an elevated FSH and LH. Yes, well, sorry. Well, there you go. I did a whole slide on it. So it's frankly confusing, sex hormone binding globulin, and it's an adjunctive test. So if it's low or high, there can be various reasons why it is, but you use it to calculate free or bioavailable testosterone, and there's no clear ranges about it, as I say. So as I say, if there's an endocrinologist on listening in, I'm more all ears to listen to why we should be doing sex hormone binding globulin. But to me, it just does seem a bit confusing, and I'm not sure it adds anything. So how do we manage these patients? I mean, this is, whilst it is a recognized clinical issue, there's been lots of studies that demonstrate that opioids definitely suppress gonadism. There's not that many that have actually done anything about it. There's a couple of randomized control trials that have looked at using patches or gels or whatever else to manage it. But looking first and foremost, all of them will say, well, we need to optimize other potential causes. So yes, if somebody's got obesity, that's another cause of hypogonadism. So we need to try and optimize that as best we can. Reduction in opioid dose, which is often challenging in our patients. Many of our patients don't want to reduce their dose. They're worried about what will happen. They don't want to use other opioids. And so therefore, it can be challenging. Testosterone replacement is, as I say, it hasn't been studied that extensively. I'll show you a couple of studies in a moment. And is there an optimal opioid that patients should be on? Is there one that's better than the other? So commencing testosterone in Australia is fraught for various reasons, including our PBS. And so commencing testosterone in Australia, I just plucked this out of the Endocrine Society of Australia. Glucocorticoid and opioid use is associated with possibly reversible reductions in circulating testosterone without elevation, where continuation of glucocorticoid or opioid therapy is necessary. Review by an endocrinologist may be warranted. Now, I've included that because I guess, well, I mean, my personal feeling is probably we should be managing it. I don't think we should be referring people off to endocrinologists. That's another time and expense for the patient and so forth. And ultimately, if we're going to put people onto treatments like methadone and buprenorphine, I think we should get more confident in managing these things and being able to do so ourselves. I can understand that people don't feel confident in doing that because I don't think the guidelines are very good. But I think as we get better at managing opioid use disorder with the treatments that we have, this should be one of our goals for the future. So these were a couple of clinical trials. These were on patients that were all on more than 100 milligrams of morphine daily equivalent. In one of them, they put them onto a gel, and in one of them, they put them onto intramuscular testosterone. And look, as you can see, the numbers are not huge. In one of them, the primary outcome was self-reported pain, and in the other one, it was body composition by DXA. So they actually look at sort of the breakdown of muscle fat and all of those things. So they, with any study, they of course don't want to just look at one thing. They want to look at 20 different things. So Basaria's study was negative because the primary outcome, self-reported pain, wasn't any different. Patients didn't get any better for being on testosterone from their pain point of view. But they obviously had more testosterone, but they did have improvements in other factors. So they did lose a bit of weight, improved emotional role. They had obviously had more testosterone and more improvement in their sexual desires. So whilst it was a negative study from the primary outcome, there were some other things that were positive. This study, which I think was from the Netherlands, was perhaps a bit better in terms of people lost quite a bit of weight. They had improved erectile dysfunction, so that dropped down quite a bit. And again, though, there was no difference in pain. So look, a lot of these studies I think have been done because they want to try and help people with their pain. But at the end of the day, it's probably not going to help from that point of view, but it might help them in other domains. This was from a sort of a clinical, a sort of a review of the literature. Most of the studies are of short duration with small sample sizes, not allowing the evaluation of long-term testosterone replacement in these patients. So, which is a common problem across many medical domains. So then looking at the two main weapons of choice that we have in terms of opioid agonist therapy, there have been quite a few studies that have shown, methadone has higher rates of erectile dysfunction, lower free and total testosterone than those prescribed buprenorphine, and odds of sexual dysfunction being higher in methadone-treated patients than in buprenorphine-treated patients. There was again another review. This is Fountas about 5 years ago that said change to buprenorphine, an opioid with milder or no suppressive effect on the HPG axis could also be another approach. So suggesting that potentially getting patients from methadone to buprenorphine might be a way to manage this. This is I'm not suggesting that this is guideline treatment or anything at the moment. I'm just talking about the evidence that's out there, but there is a little bit creeping in. And look, in terms of our research, so the rate of hormone suppression, as I said earlier, was comparable for women against men. This is all the women we had in the study. There's quite a number who'd actually reached menopause, obviously being a study that's a 20-year follow-up. A lot of them had reached 50 and beyond. Looking at, so each methadone increment of about 10 milligram, each increased odds of hypogonadism by about 20%. So not insignificant. So you put somebody on enough methadone and eventually, it's very, very likely that they'll end up with hypogonadism. Also, clinical depression was associated with threefold increase in risk of hypogonadism. So, I think there's been a lot of studies over the years that have shown that hypogonadism is associated with depression, and a lot of studies that have shown that opioids are associated with hypogonadism, but there weren't that many that sort of said, well, hang on, we're putting people on opioids, we're giving them hypogonadism, and that's associated with depression, and that's kind of what we were getting at in this study here. This is all under peer review as we speak, but hopefully we'll have it published soon. As you can see, testosterone levels across in males were decidedly lower in the methadone group. It actually didn't reach significance compared to the buprenorphine group, only because of the statistical power that was lacking. So there's only 17 people on buprenorphine, so not enough to reach significance, but it certainly reached significance with the people who were not on opioid agonist treatment. Again, LH and FSH were lower, and again, I think it was from off the top of my head. We were only able to say they were lower with the LH, which, as I said before, is higher, which is more suppressed by opioids. So, what to do now? Assess for other causes. So make sure you're looking at their prolactin, their iron, the diabetic status, optimizing their opioid dose. So if you can get people down a bit, that's good. Look for the sequelae. So doing DEXA scans, trying to monitor their weight and optimize their weight. I don't want to talk about GLP-1 agonists tonight, but that's obviously an increasing area of interest in the addiction space as well. Maybe we should be getting people onto testosterone, and maybe we should be getting people onto buprenorphine as well. But certainly, I'm lucky enough to work in a very large metropolitan hospital with an endocrine department that's sort of happy for us to try and get in touch with them for some specific advice, and we're going to be working with them closely over the next little while to see if we can sort of start to improve some of the management of these patients. Before I go on to the hypothalamic pituitary axis, I saw there was a question in the chat. So there was a couple. There was one: is the effect related to age of patient or methadone itself, do you reckon? Well, so firstly, I mean, testosterone will go down with age as it is. Yeah, look, my personal opinion is that probably methadone is more hypogonadal than buprenorphine, but it's hard for me to say that with the limited amount of evidence that exists. We probably need a bit more evidence of it. And as I say, in our study, each increase in dose increased the odds of getting hypogonadism, which is a dose-dependent response is pretty important. If there are associations or confirmed causes, yeah. So no, great point. So most of the the research that we've done and a lot of the studies that are out there are not randomized controlled trials. So therefore, we can only say they're association, not causation. So that's a valid point. With testosterone taking, is there a time from waking measurement time instead? A lot of patients often wake. Yeah, this is a really good point. And actually something that I might talk a little bit more about when I talk about the adrenal axis. I certainly think that patients probably do have some unusual hormonal patterns as a consequence of their different lifestyles. There was a patient in the study who I believe was a sex worker, and so as a consequence, most of their work was overnight, late at night, and they didn't get up usually until in the afternoon. And unsurprisingly, the one day we did get them up to do this testing, their cortisol was like 47, so incredibly low. And then we repeated the test down the track, and it was okay again. So yeah, I think that's a really, really valid point and probably something that be worthwhile to look at as well. Do we need authority for testosterone? Great question. I don't know. I haven't ever initiated treatment for testosterone. My understanding is you do need to get an endocrinologist to sign off on it, but I don't know. If anybody knows the answer to that question, I'd be very interested. Okay. So then moving on to, oh God, that's meant to say adrenal. Gosh, not gonadal. So where do opioids act on the hypothalamic pituitary adrenal? That's adrenal axis. Thank you, Brian, for confirming. Yes, it needs to be commenced by an endocrinologist or a urologist first. That was my suspicion. You can prescribe on a private script as well. Okay, yeah. I mean, yeah. I think this. I think that's what I was saying before about the PBS. So you've got to, if you want to get it on the PBS and therefore cheap, then you've got to be able to show the levels and get it initiated by an endocrinologist or urologist. Whereas if it's not, then yes. All right. So has everyone had a chance to answer that? Thank you, Kathy, for sharing the criteria as well. Ooh, little split in this one. People unsure whether to go listen to whether it was the same as with the HPG axis or whether to go the standard MCQ trick of going all of the above. In this case, it's all of the above. So it does actually work across all the different levels. This is a great little diagram that was put together by Vuong in their little review of the hypothalamic pituitary adrenal axis. And I mean, there's been studies that have shown that you can have, both a positive and negative effect across really almost all of the axis, but in the adrenal glands itself, it definitely has a negative effect. It really, I mean, for the most part, especially when you're using it chronically, it's mostly a negative effect. There is some evidence that when you use it acutely, that you can create more corticotrophin releasing hormone, but only when you're doing it acutely. So yes, the opioids blunt the pituitary's response to corticotrophin releasing hormone, which is the hormone that the hypothalamus releases to cause the pituitary to release ACTH, adrenocorticotrophin hormone. Is that right? And that's what causes the release of cortisol from the adrenal glands. Mu and kappa opioids are on the adrenal glands, and we get suppression of ACTH as well as cortisol. Excuse me. So again, this is somebody collaborated some data and found that it was probably about 20% of people who are on opioids chronically get some level of adrenal insufficiency. And that was about what we found in our paper as well. This was a little diagram I made, which is looking at all of the patients we had in our study to look at their ACTH and cortisol levels. So ATCH being what causes cortisol release. And as you can see, so the dotted lines are the cutoffs, or what would be considered normal or abnormal. So in our study, we used 166 as the cutoff for cortisol, which again should be tested in the morning. And again, these things with cortisol in particular, there are testing that should be done to test the adrenal gland in order to see where the deficits lie. And I'm not going to go into all of that today, but as a screening tool, you can do an AM cortisol, and you can see that for methadone, buprenorphine, and other opioids, that there were plenty of people who had both a low cortisol and a low ACTH. So if your cortisol is low, your ACTH should be high. Whereas those who were opioid free, there was no one. There was no one who had a suppressed cortisol. There were a few people who had what you would consider a normal ACTH level, but yes, there was none with suppressed cortisol. So the symptoms are much more vague for patients who've got hypocortisolism. Fatigue, weakness, loss of interest in food, muscle pains, mood changes, nausea, vomiting. Postural hypotension is less pronounced due to patients still get aldosterone. Due to the renin-angiotensin aldosterone system. So, as I say, the symptoms do tend to be a bit vague. And as a consequence, there's even been a case, this was by Stephen Twigg, who was one of our co-authors for the study that we were doing, that showed that if they had opioid-induced hypoadrenalism that was significant enough that it caused hypoglycemia as well. Again, are there differences in opioids? Well, there was this paper from about 5 years ago that suggested maybe people who are on oxycodone are more likely to get it than those who are on other opioids. Our study, we didn't really find any difference across the participants, so there was no real clear difference in cortisol levels or anything like that. Does it persist? So, this is one. There'd been one paper that had suggested that potentially the suppression of the adrenal gland could continue even after people stop opioids. So we divvied people up into people who were on opioids in our study and people who were opioid free. So we had about 35 people who were not on any opioids. They had previously had heroin dependence, but they were no longer taking any opioid agonist treatment or heroin or anything like that. And as you can see, not one of them had a case of hypocortisolism. That's this down at the bottom here. And only 2 of them had hypogonadism. So, and both of those participants had obesity. So probably more likely that was the cause of their hypogonadism than anything else. So there's probably no persistence of these. And there also didn't appear to be any sorry, there was a small association with the amount of time people had used heroin for, but I suspect that was probably more likely just reflecting the fact that people who had used heroin longer were still using heroin and therefore on heroin at the time of the study. So moving on to the thyroid hormone and prolactin. So thyroid, there's been really limited data around thyroid studies and opioids, but it's really mostly been negative. And there was nothing in our study. There was a few people there was one person who had hyperthyroidism. There was about 10 or so who had hypothyroidism, but all had sort of clear reasons as to why they had hypothyroidism, like they had Graves or whatever else. Interestingly, most studies show opioids elevate prolactin. Our results were a bit unusual. We had quite a few that had an elevated and quite a few that had a suppressed prolactin. There was one animal study that showed chronic administration of opioids led to reduced responsiveness. So whether or not the people do develop tolerance over time, and whether or not this has anything to do with dopamine, given the potential effect of dopamine on prolactin as well, not sure. Um, So interestingly, when you go through the literature, you sometimes end up back where you started. This was a study from 1980, and they gave naloxone to healthy volunteers, and so naloxone being the opioid antagonist, of course. And they noticed that there was a drop in cortisol, luteinizing hormone, FSH, and insulin, but there was no change in growth hormone, prolactin. So we've done all this research only to sort of end up a little bit back to where we were, as it were, but nonetheless. I just thought I'd talk quickly about, I know I've not got limited time here, but just talk about some metabolic um, impacts of opioids. I know that's probably a whole other topic in and of itself. So which opioid has the most evidence of weight gain? Do people want to jump in now? While we're doing that, I just noticed there's a couple of questions. If opioids affect all HPA, then wonder why not affecting thyroid? Um, Oh, so sorry, I did make that clear. So it affects all of the hypothalamic pituitary adrenal axis. So it affects the release of corticotropin releasing hormone and adenocorticotropin releasing hormone, which then affects which then causes the release of cortisol. Uh, Thyroid is released, so the axis for that is different. So it is thyropoietin releasing hormone, which then goes to TSH, thyrotropin stimulating hormone, and T4 and T3. So it's a different axis. So therefore, and yeah, no, but it's a good question. Why are those? Why is the release of those hormones not affected by opioids? I'm not sure. Was the prolactin level adjusted by if they're on concurrent? Yeah, really great question. We did actually have a look through. So people who were on antipsychotics did have, yeah, that was there was a slight association, but it wasn't as pronounced as I expected it to be. But yes, we did account for that as well. It wasn't the entire thing that explained why so many of them were in opposite directions. Oh, yes. So most of you identified methadone. If you look into the studies, there's no doubt about it, really. Methadone is associated, most people who start onto methadone will gain about 5 to 10 kilos of weight, which is not insignificant. Not to say that the other ones are weight. Well, look, most of them are either weight neutral or slightly weight positive, but methadone is significantly weight positive. So my brethren, the Italians, in the 1970s did lots of studies about opioids and insulin resistance. So heroin use delayed insulin response to a glucose challenge. That was by Brambilla. And there was noted that people on methadone or using heroin had higher basal insulin levels and then sort of more sluggish responses to that as well. So this is something that we've been aware of since the 1970s. There's lots of different theories as to why this happens, whether or not it's in terms of insulin resistance. So we've got insulin works on cells to help facilitate the uptake of glucose, and there's various pathways that are involved in that. And this IRS1 PI3K AKT pathway is particularly important, and the GLUT4 vesicle is also particularly important. So this pathway basically causes the GLUT4s to take up the glucose that's there, and it's thought that perhaps potentially that's the interference of that from methadone in particular that might cause insulin resistance. There's other theories though, so maybe it's the hypogonadism itself, maybe it's the hypercortisolism, or maybe it's the weight gain that methadone causes that does something. So looking again at methadone and buprenorphine, there was a couple of studies that compared them to see whether or not methadone was perhaps worse. Elements suggested that there were higher rates of metabolic syndrome and higher glucose compared to insulin. And this study by Farid suggested that the 28% of people on methadone had diabetes, but there were some confounders in this study, and that there was a lot more people with racial propensity to have diabetes, and also people on buprenorphine do tend to be younger. Buprenorphine didn't exist, really as a treatment option until sort of only 25 years ago, and so as a consequence, a lot of the people who take methadone are older, and that's certainly consistent with the numbers we see around them. So looking at our research again, we had 12 people who had diabetes. I believe 4 of them weren't even aware. So we had 4 new diagnoses of diabetes, which is quite incredible. And 5 of them were complicated. So they had evidence of proteinuria. But we did what's called a quickie. So no, it's not what you're thinking. It's basically where you take a glucose level and an insulin level, and you can calculate somebody's level of insulin resistance based on that. And excluding all of the people who had diabetes, we found that there was another, almost half of the cohort had some level of insulin resistance, which was quite an astounding finding. At the same time, I'll also add, so as you can see, there's probably a higher propensity of people on methadone who had insulin resistance, and similarly, their BMIs were a lot higher. So people in the methadone, on methadone, were almost the mean weight was a BMI of 31, which would put you into the obese range of weight. So just being on methadone gave you a more than 50% chance of having obesity, which is quite astounding. So look, I remain a bit skeptical that methadone in and of itself causes insulin resistance outside of the weight gain. I think it causes weight gain for reasons we don't fully understand. And whether or not it causes insulin resistance beyond that, I don't know. But it certainly is reasonably weight positive. That is a very, very, very quick whirlwind tour through some of the endocrine systems. We've got about 10 minutes. I'm more than happy to answer some questions. And I note that there was one here. Muscle loss may correlate with lowered insulin sensitivity. I'm not quite sure I understand the question. Schreider, can you maybe clarify that question? And I'm more than happy to try and answer it as best I can. I note also that Kathy, thank you for posting the criteria for androgen deficiency. So you've got to have an established pituitary testicular disorder. And this is where it's tricky. I mean, yeah, do we consider opioid-induced hypogonadism an established disorder, as it were? But then, yes, must be treated by a specialist pediatrician, endocrinologist, urologist, fellow of the chapter of Australian chapter of sexual health. So, or have an appointment to be assessed. So, yeah, I mean, I'm sure there are ways of getting around that. Like if you work in a tertiary level hospital, then you could say, oh yes, they're going to go and see the endocrinologist there, and that consists of an email to them or whatever else. So yes, Shrader, you said insulin receptors are heavily populated on skeletal muscles, so the muscle loss may correlate with lowered insulin sensitivity. Yeah, okay, I see what you're saying there. I don't know. I can't comment on whether or not that's correct or not, but it does make sense. Kathy's also followed up to say, unfortunately, it also says the condition must not be due to age, obesity, cardiovascular disease, infertility, or drugs. So yes, that does make it very challenging. And how much people want to be truthful with the PBS, I guess, is their own choice that we all make on a daily basis. Did anybody else have any other questions? I'm guessing that that's probably a wrap then. Oh no, maybe not. In your clinic, do you test and treat or leave to GP? Yeah, I do test quite a bit. And then a lot of patients sort of say, well, you know, thanks, doc. You know, like I try and test as much as I can, but not many of my patients are not that interested in all of this, unfortunately. Um, and no, look, in terms of treating, as I say, I really don't have enough experience with it myself. I feel a bit, I feel a bit of a fraud, a bit of a, bit of an academic fraud in that I'm sort of looking for these things and talking about them a lot, but not really doing much about it. So, as I say, we are establishing a bit of a relationship with the endocrine department in our hospital to try and manage more of patients like this. But yes, unfortunately, it's a bit of a gap at the moment. Since OSA is a contributing factor, should we screen more for OSA? Absolutely. I've noticed that there's a lot of pharmacies are getting on board with doing testing for obstructive sleep apnea, doing home sleep studies or lending out the equipment and so forth. And I think that's brilliant. I think there should be probably a bit more of that. I think that ultimately, if we can avoid having to send people off to respiratory physicians or whatever else, then that's a good thing, and we just do the test. I don't do the test ourselves and get them started onto treatment for that. Absolutely. What is the verdict on considering positively treating androgen deficiency? I mean, I think we probably should be putting people onto testosterone if, or estrogen where the need is. There's absolutely nothing on treating women in this space, so we need to do some more work on that space. But I think for men, there's no reason we can't put people onto testosterone and hopefully help with their weight gain as well. Can I show my slides? Absolutely. None of the patients in OTB seem to use it expense or difficulty accessing, or not great at caring for themselves. Yeah, and look, this is, I could probably, I offer testing to, almost all my patients, and it's hard enough to get, a bloodborne virus screen, let alone to get testing of testosterone or whatever else. So, yeah, it is, unfortunately something that's just not a priority for patients for understandable reasons. But hopefully I think if we get more and more treatment, if we can start to get people, we can start linking in with endocrinologists, start getting confident in treating this, then maybe, it's, one thing I've found with our patients is that once one person starts to get treatment for something, a lot of others will follow. So I think it's something that we can work on down the track. Another motivating factor to take people away from methadone? Potentially, yes. I mean, I think there is a bit of evidence there that it's probably buprenorphine is better in terms of weight loss, and well, not weight loss, but less weight positive, and hypogonadism. Do you see much? Oh, yeah, it's Testo Gel 1%, 2 by 60 pumps, private price 7. Oh, okay, so not too bad. Do you see much hyperprolactinemia with opioids? Yeah, well, so as I say, like our most of the time, there is a hyper. Our study was a bit unusual in that it had hypo and hyper, so it was a bit odd. I've seen a few, and a lot of the time you could find a reversible reason. So like they were on an atypical antipsychotic or something else as well. Any other questions before I let people get on? Could switching to buprenorphine improve how if we switch a patient experiencing hypogonadism, or is it a more prophylactic potential? Um, yeah, look, there hasn't really been a study to demonstrate it. It would be a very hard thing to study, like, getting some people on methadone, finding enough that have got hypogonadism and then switching them to buprenorphine and then rechecking the results. Probably would have been a good thing to do when I was doing the microdosing study. So it would be a very challenging thing to do, but I think over time the evidence is increasing that buprenorphine's better. We probably just need more and more studies so that we can more and more put together. It's once you've got enough numbers to suggest that there's a difference, some smart person out there can go and do a meta-analysis and establish that it's better. Was physical activity different between the groups on opioids versus off? Great question. There was data around what they ate, like were they ticking the goals of like 5 veg and 2 fruit. There was no difference in that. I can't remember for the physical activity. I don't think that was captured. I'm sorry.
Thank you, Chris. Very perfect, very interesting presentation. Thank you all for joining us this evening. I hope you found the session helpful and informative. Special thanks to our speaker, Dr. Chris Tremonti, for his excellent presentation. The presentation slides will be available shortly on the OTAC website, and you can also watch recordings of previous webinars on the OTAC webinars page. If you have any suggestions for future topics or clinical cases you would like us to cover, please feel free to email us at the OTAC mailbox. Our next webinar will be on Tuesday, September 23rd at 6 p.m. with Dr. Michael McLean presenting on palliative care and opioid use disorder. We look forward to your attendance. Thanks again and have a great night.